Hands, you either have a child under the age of 10 in your household now or have had one. We had this in our house until I was so frustrated with it because it doesn't work. You're supposed to build these pieces and then drop the marble, and it's supposed to merrily go along the track and plop in the end. It never works. A true story, one night when the kids were asleep, I disappeared the box and took it straight to Goodwill. My point is, so many of our healthcare components, sites of delivery, all well-meaning, but they don't flow seamlessly. So you have to start thinking about how you can break down some of those silos and reach out to the partner before you, that came before you, or is going to come after you, so that your patient is the constant and gets as seamless care as we can make it. Here's an example of what we've tried to do here at Christiana Care. We participate in a bundled payment care initiative, trying to basically streamline care for a patient who's having joint replacement surgery. Here's that example. So we had to work out, how do we put all these pieces together? And a lot of groups got together and broke down walls so that a patient who's having joint replacement surgery, one of the constants is the CareLink team. So we engage them before surgery, when it's a scheduled surgery, start talking to them about what it's going to mean to have surgery, what it's going to mean to recover sensibly and safely from surgery. When they're in the hospital, there's this huge group here in the hospital that does wonderful work with them, and the CareLink team's right there. And then afterwards, what is it going to take to keep them healthy, recover well, make sure they get to therapy, make sure they keep all their other chronic conditions in good check. And there too, the CareLink team is their constant, helping them navigate all of that. Another component, it's awesome to have IT infrastructure and communication infrastructure. And as you heard from wonderful speakers this morning, we're all aspiring to it, and we'll get there. Let me tell you a little bit about some of the fun tools we have here. So we've been lucky enough over the years here to have our IT team develop some of this for us. And so we are able to get a lot of great data feeds from the Delaware Health Information Network, which is this state's Health Information Exchange, and the CRISP, which is Maryland's, which is also awesome. We're able to get data feeds from claims, from insurers of patient groups that we're taking care of, and from our own hospital systems. And from health records of some of the other partners in the care of the patients that we're taking care of, partners up and down the state, actually, other health systems. And we're aspiring to getting biometric device readings in. That's the next frontier for us. And then I mentioned we use a prediction engine to tell us which are the patients that need our help the most. And we take all this these sources of data and populate bits of valuable information into our population health record. And we're also trying to reach out to patients through a member portal. So what does this really mean? This is one of the greatest things that we work with every day, which is we get alerted or sort of pings from the Health Information Exchange when one of the patients that we're taking care of has an admission to any of the hospitals or emergency departments that report to the Health Information Exchange. And it's really great in real time to get a notification. Here is a fictional patient, Perry Mason, has had an admission at the Bay Health Medical Center down in Dover. But we're in charge of trying to help this patient. So regardless of where he's gone for his care up and down the state, when we know this, we can be proactive. When we get these pings, we can call down to the ED at Bay Health and say, how's this patient? We're taking care of him. What kind of information can we give you? He's got this robust care coordination team behind him, and he's got all these docs and other providers. It basically, again, trying in real time to smooth the trajectory for this patient. Another great asset from this IT enhancement is we get lab notifications from any of the labs that report to the Delaware Health Information Network. So if one of our patients with CKD also happens to have diabetes and it's not in good control, and he or she gets his A1C drawn at a community lab, we will get this ping, this trigger. And that'll trigger us to call the patient, say, we see we had this lab drawn, it wasn't so, you're not in good control. What are we doing about it? Do you have your follow-up appointment with the PCP to discuss this? And in case the answer is no, then our next statement is, how can we help you get that going? Do you need transportation to it? What's the barrier? Why haven't you made that appointment? And how can we help that remove that barrier for you? But it's so much of a privilege to get these kinds of triggers in real time, because you can enact change in real time. And the final component is, it's nice to take a step back sometimes when you have populations that number in the tens or hundreds of thousands, to be able to step back and just look at your whole population in a big view, again, to filter and slice and dice. But it's also nice to go down to a very granular level. We are on the cusp of getting information at this detail about our patients of interest, where this is shows you this patient, who happens to have chronic kidney disease as well as several other conditions. This is a global view of all the various places he has received care. Now, until we had a view as global as this, if I was this provider who had a visit with him in January, I wouldn't know that there were all these other visits. Sometimes these are with other care providers. Or if I saw him here, sometimes I didn't realize that there was a 3-month hospital stay here. It's so nice to get this global one-shot view and then use it to enable the conversation with the patient and all the people who care for him. So just to give you some tidbits of how we're progressing and using those enhancements, I mentioned our bundle payments program. Here's some of our first results. And one of the measures we focus on very much is decreasing readmission rates. Because one way to think about it is, if your patient is doing well after having surgery and recovering as you hope, one would think they would not need to go back to the hospital. None of us wants them to. So we've been watching very carefully to see and make sure that our readmission rates are dropping. And it's really gratifying to see that they're down and they're staying down from our baseline before all of those changes are put in place. So as you can see, our 7-day readmit rate has dropped by 15%, and the 30 and 90-day readmit rates are above 20% and holding. Another subgroup that we started our work on is the congestive heart failure group. There too, with a big focus on readmission reduction, again, as a sort of proxy measure for better health after leaving the hospital, in that they're doing well enough to not have to go back within 7, 30, or 90 days. And there too, we've been happy to see a drop that's sustained over 90 days and has been sustained over the months since we started working with this group. So the bottom line is, we're all here today to talk about moving the needle from reacting to acute illness in our patients with CKD, but really to looking to give them more disease management and support, looking at the big longitudinal picture. And what you really want to do is get to a state where they achieve good health, good stable health, and one of the components, I think, is complex care coordination. We're really trying to utilize and maximize what we think we can do with that to get our patients healthier. I'll stop there, and I'm very happy to take questions if we have a few minutes for it.